right, so today we are in week 5. It's fall 2020. This is Bio 208 with Dr. Granier, and we are talking about blood pressure. Okay, and one of the things we talked about with blood pressure is the flow equation. And the flow equation is usually designed as Q, which represents flow, and that can be airflow or blood flow, is going to happen. So flow of a fluid or flow of an air mass or air winds, whatever, current, is going to happen when you have a pressure gradient, so a delta P, an area of high pressure versus an area of low pressure, and that pressure gradient is sufficient to overcome all the sources of resistance. And we talked about for resistance that length or distance is one of our components, and for most of us, we are not actively growing longer or taller or wider with every given heartbeat. So length is normally not something that is going to be a short-term rapid change to our resistance component. All right. Viscosity of the blood is normally going to be one of our resistance components, and most of the time, second by second, I can't make my blood thicken or water down itself in a split second. That's also a component that normally stays pretty constant. However, if you go super hydrated with too much IV fluid, too much fluids in the system, or reverse that, you get super dehydrated very quickly, then viscosity can come into effect. Okay. The other components are the velocity, the flow velocity, whether we have laminar flow or whether we have turbulent flow. All right. And the turbulent flow, remember, is going to be usually when the vessels are more restricted, have a smaller radius, or when they are getting larger than normal amounts of fluid pushed through them, that the fluid cannot flow in a laminar way. And the laminar versus the turbulent flow is going to be very, very big on influencing if those endothelial cells are becoming damaged. And so normally where we see more laminar, more high resistance to again the flow, that means that the flow is more turbulent in some of our like carotids and our high pressure receiving vessels, the aorta, the coronary vessels. That's where we normally are going to see the higher risk of those occlusions and atherosclerosis setting in. Okay. All right, the gravity effects. Gravity can be our friend at times with helping us when we think about laying people down, gravity, and then lifting their legs. Sometimes gravity can be a helpful thing in terms of helping us create a pressure gradient to bring blood back to the heart, all right, and increasing our EDV and increasing our cardiac output. On the flip side, gravity can be our not so good friend, especially when we're upright and when we think about the relationship of our heart to the top of our head. So if we had really long necks like giraffes, gravity might not necessarily be our friend. And then anytime gravity and gravitational forces increase. And for most of us, that's not normal, but back in my Air Force days where I dealt with a lot of fighter pilots, increase in gravitational force with flying maneuvers and having high maneuverable aircraft, it was a huge deal. And so we had to train, and for some people, if they were just physiologically not able to overcome these high G-forces and the onset of those G-forces, and they were prone to incapacitate because of the G-forces, that could be the reason why they weren't able to fly F-16s and F-15s and F-22s and F-18s even. And so it started day one in pilot training. So about a year before you knew what airplane you were going to, there was a protocol in place to start training your body to increase your muscle mass. Why? Because we remember muscle mass and skeletal muscle contractions and muscle tone and the muscle ability to push on the veins forcefully, especially when we contract those muscles on purpose, is part of how we help get blood back up to the heart and increase in diastolic volume. And fitness was also a big component of, if you're in an airplane, you don't fly for 2 or 3 minutes. Sometimes you're in an airplane for 6 to 8 hours, and if you're refueling, for longer. And so being able to pull these high G maneuvers when you're 6 hours into a a mission because it took you maybe 2 hours to fly someplace, and then you're flying circles in the air watching for the bad guys to launch their airplanes and engage with you. That means you need to be able to, again, fit-wise, be able to do these massive contractions and muscle contractions and weightlifting, kind of like squats and crunches and lunges, when you're 6 hours or 8 hours into a mission. All right. So gravity is normally our friend, but it can, or normally gravity can be our friend or it cannot be our friend. Normally we're dealing with 1G forces, but again, there are certain situations where that can change. All right. And we know with there's like negative pressure suits and there's positive pressure suits, and there's ways we can manipulate maybe some of the forces like gravity does on our bodies with hyperbaric chambers and different things like that. So not hyperbaric, that's pressure chambers. So, but there's ways we manipulate the pressure gradient. Okay. I'm losing my train of thought. All right, so the most important factor of resistance, especially in the short term, is going to be how we manipulate on the systemic arterioles, how we manipulate the radius of the vessels. And because the arterioles, that part of the vascular network, so not the capillaries, but right in front of it, the arterioles, because they collectively, there are a lot of them, and they collectively are all constricted to some degree. They are all going to be collectively a huge source of resistance to blood flow into the capillaries, because they're trying to take the 60 mils of fluid that is your stroke volume for a given heartbeat, and they're trying to manipulate that 60 mils into every capillary bed to make sure that there's enough to spread around. All right. And they want to make sure that it's uneven distribution. So one capillary bed maybe gets 0.05, one capillary gets 0.03 milliliters. So it's getting, little bits of blood to a lot of capillary beds. And so those arterioles, they're already constricted to a large degree. And by the rule of smooth muscle, if I get a kind of a large percentage of them, and even a small percentage of them, if I get just some numbering or some amount of those arterioles to collectively all constrict 1 to 2% more, that's going to really amp up the resistance even more so to like a fourth power that I then now have to overcome, which means the pressure gradient I have to generate is going to be more, which means the starting or the blood pressure at the left ventricle pumping out is going to have to increase. All right. Versus if I can get those arterioles to dilate to a small amount, maybe 1% dilation over 20% of my arterioles, again, that amps to the fourth degree. And so the effect of now my resistance dropping so significantly might mean that my pressure gradient that I have to create, so I have to have like a pressure gradient of 50 millimeters of pressure. So I need to have the force available of pushing mercury 50 millimeters in height. That might go down to now I only need a pressure gradient of being able to push on mercury up to 30 millimeters in height. And that might be that now my left ventricle doesn't have to push that 60 milliliters of fluid as forcefully with as much effort and exertion on the cells in the heart. And that then maybe helps the heart slow down a little bit and maybe not induce as much contractility and calcium handling issues. Okay, so those are our 4 forms of resistance. All right, and so in the short term, because viscosity normally doesn't change, because gravity really doesn't change, because the length of the body doesn't really change, when we look at short-term changes to the blood pressure that we need at the start from the left ventricle to be able to, again, ensure that blood gets through the elastic arteries, through the muscular arteries, through the arterioles, and then pass and through the capillaries into our veins, and then with a little bit of pressure in the veins that we can start to suction it back up without gravity's assistance in some cases, to the right atria, where the atrial pressure can be anywhere from 0 millimeters of mercury pressure to 2 millimeters of mercury pressure. We want to make sure that, again, the arterioles, where the greatest amount of pressure gradient is required to get through that stopcock, through that tunnel, through that little passageway, that we have enough at the start. Okay, and usually the radius of those arterioles is the location, is the target for when we want to make the starting blood pressure, and therefore the gradients all the way through all shrink down a little bit, so the starting pressure can start at a lower amount. That's usually the place where we target the systemic arteries and the arterioles, their radius, and if we can make them a little bit bigger, we can make the starting pressure and the pressure gradients we need all come down. If blood pressure goes up, chances are in the short term, it's because some of those arterioles and some of those muscular arteries, but usually the arterioles, a bunch of them have started to constrict, causing, again, the starting pressure to have to go up, so I have enough pressure at that point in the vascular tree to get past it with the pressure then needed to continue the blood to flow to the next part and to the next part and then back up to the right atria. Okay? Now, when we rework, so the equation, remember, for cardiac output, all right, is cardiac output is equal to heart rate times stroke volume. And remember, stroke volume is EDV. All right, that's a V minus ESV. And remember that ESV has this component called afterload. Okay, so anything I do to resistance of arterioles, of systemic arteries, is going to usually influence afterload. And by influencing afterload, I make ESV go up or down. And remember, if I make ESV go up, stroke volume should go down. And if nothing else changes, cardiac output should go down. On the flip side, if I make my resistance decrease, then ESV should go down, which should then make stroke volume go up, which should then make, if everything else holds true, nothing changes, cardiac output go up. All right. Now, if I was to say cardiac output is 5 liters per minute, and I say that is the amount of flow of blood I want to occur in my cardiovascular system, all right, I can label it Q. And remember, my flow equation is equal to that delta P over R. All right, and delta P represents the highest pressure I need to be able to flow to the lowest pressure. All right, and I have pressure gradients in the segments of the vascular network. All right, and again, usually to get 5 liters of my blood from the left ventricle to the right atria, I need that average blood pressure, my mean blood pressure of 100 millimeters of mercury, and that blood pressure on average between my systolic of 120 and my diastolic of 80 on the left ventricle is an average of 100. It's usually enough pressure to be able to get through the elastic arteries, and maybe, again, the left ventricle pushes it out at a mean of 100 to get through the elastic arteries. Maybe I drop 10 millimeters of pressure going that distance through those radius, all right? And then to get through my muscular arteries, maybe I drop another 10 to 15. So maybe I'm at 70 now, okay? And no, you don't do calculations on the test. Remember, if there's any calculations, it's very easy calculations. It's physiology, public math, all right? And then to get through my arterioles, all right, remember that the arterioles are the biggest point of pressure that I'm going to overcome, the biggest gradient. And so to get on the other side of arterioles, I usually want somewhere around 25 to 30 millimeters. So this delta P of 70 to 25, I don't do really well on public math, but that's like 55 millimeters of pressure is lost, because remember, all of these arterioles have different radii and there collectively is a bunch of them. And then to get through the capillaries, at the end of the capillaries, maybe I'm at 15. And then to get through some of the veins, again, I'm anywhere from 2 to 7 for my millimeters of pressure. All right, so that's kind of this whole thing of, again, my cardiac output. My P is on average, can also stand for the blood pressure that I'm trying to achieve at the start when the left ventricle pushes blood out. And if that number is right, it should be able to get 5 liters of blood from the left ventricle back into the right atria every minute, and it should overcome all of the sources of resistance that are in every segment of the vascular tree. Okay, and as we go through each segment, a little bit of that pressure gets lost because, again, that's the pressure that we're bleeding off as we travel that distance, as we overcome the velocity issues, as we overcome the viscosity issues, as we overcome the gravitational forces and everything else. Okay? Now, if you redo these equations, all right, and you say now that for my, again, starting equation of flow is equal to now my mean blood pressure that it takes to get from the left ventricle to the right atria over my sources of resistance, which can also be written as total peripheral resistance. All right, I could say then, again, if I take the R and solve it, and Q is actually cardiac output times resistance is equal to pressure, delta P, which again is that mean blood pressure that I need to start with. Okay, so we're just doing, again, reason why you have to take algebra right here, justification for that algebra class. This is what we're, using it as. All right, and so anytime, and again, on average, most of the time, my starting blood pressure, my systolic is 120, my diastolic is 80, my mean blood pressure is 100. All right, that 100 is normally enough to get my 5 liters of blood moving from the left ventricle to my right atria, and as it's moving, it's overcoming all the resistance in the elastic arteries, all the resistance in the muscular arteries, all the resistance in the arterioles, all the resistance in the capillaries, all the resistance in the venules, all the resistance in the veins, and all the resistance to get back into the right atria. Okay? All right? And because the R is, again, components of it. Its components are the radius, the length, the viscosity, a little bit of flow and gravity can come into play here. As those components change, blood pressure might change, cardiac output might change. Okay? So let's talk about, again, since the radius is usually the easiest component to manipulate in the short term, what are things that make the radius of most of my vessels contract? Well, these would be things like sympathetic outflow. What are things of sympathetic outflow? Epinephrine and norepinephrine. All right, so anything that causes sympathetic outflow, norepinephrine and epinephrine, is going to make a large number of my arterioles contract and constrict their radius 1, 2, 3% more. All right, and because they are going to constrict the radius, okay, they are going to make my resistance to flow go up through the roof. All right, and if my resistance goes up and my, let's say for now, cardiac output does not change, so all of the sympathetic flow is just on my resistance, okay, my blood pressure I'm now going to need to force my 5 liters of blood through my system is now going to need to go up, because when I go through the arterioles and when I go through some of my muscular arteries, I am going to have smaller radius for a lot of those vessels, and those smaller radii are going to mean that I am going to need to push blood through and spend more energy doing that, more of my pressure bleeding off in that segment to get into the next level. And so I'm going to need to maybe have, instead of 100, 130 for my mean blood pressure. Okay, and if that's the case, my systolic pressure is probably going to need to go up, and that diastolic pressure might even need to go up a little bit. So the average that I create between systolic plus diastolic divided by 2 is a larger number for my mean blood pressure, so that way I can overcome the resistance that's happening when my epinephrine and norepinephrine releasing more of their effects on the vasculature. Okay. Other things that can cause the vasculature, again, a large portion of it to contract and therefore constrict, would be things like prostaglandin, maybe adenosine, high levels of potassium, and some hormones. And some of the hormones that can do this are, in high amounts, ADH from your pituitary gland. Remember, ADH from your pituitary gland is normally working at the kidneys, but in high amounts, it's going to cause arterioles to constrict. All right. And then the other big guy that's going to do this is also from your kidneys and relates to retaining blood flow, but it's angiotensin 2. It's from the RAS pathway, the renin-angiotensin system. And again, angiotensin is going to work to raise your blood volume and retain fluid at the kidneys. But again, when you have really low blood pressure, it's also going to start to make your vasculature constrict. And the goal would be all those radiuses get a little bit smaller, so you then need potentially more force created to be able to push through them. Okay, so those are some of the ways that, again, I could probably make my blood pressure go up. All right, now how do I manipulate and check myself and regulate my blood pressure in the short term? One of the big ways we do that is through the baroreceptor reflex. All right, now the baroreceptor is a stretch receptor that is located in the aortic arch and in the carotids. All right, and part of what it's doing is it's going to see if the blood leaving the left ventricle, if that stroke volume is enough to stretch it, so that way we know that blood heading to the brain should be sufficient because it's stretched the blood vessel to the right amount to get into all the capillaries of your brain. Okay, and same thing with the aortic arch, that you're sending enough stroke volume and stretching the aorta enough that you're getting blood possibly sent to the capillaries and all the extremities. All right, and so this reflex is only measuring stretch. Okay, it is not telling me if the blood I'm sending is actually rich in oxygen. There's a different system of receptors that are sensitive to, is the blood coming out of the left ventricle oxygen rich or carbon dioxide rich or super acidic, and therefore probably full of carbon dioxide. Okay, so this system is only telling me, am I sending enough blood to get through all my capillaries? And the system works really well at sensing if I'm not sending a lot of blood that's going to then be able to get into all of my capillary beds. All right, and so the way the system normally works, all right, and this next slide shows it really well, is if I am not getting enough stretch in these critical areas near the left ventricle, okay, I am going to then want to use my baroreceptors, which are saying normally like this rate of frequency is, we're right on, we're getting blood to the capillaries. And all of a sudden, if the rate goes less because I have less blood getting to the out of the ventricle, that is going to send a signal through those baroreceptors to the medulla oblongata area of my brainstem, to that cardiovascular monitoring area. And that cardiovascular monitoring area is going to see that the rate of the firing or the rate of stretch from the baroreceptors, thus the amount of fluid entering and stretching those vessels, is not sufficient. And if that's not sufficient, it is going to try to get sympathetics to be released. All right, and when we release sympathetics, we are going to see that the first order neuron is going to go into the spinal cord, then the spinal cord is going to send out the preganglionic fiber to the sympathetic chain ganglia in that thoracic region. It's going to exit out of the spinal cord, and then the postganglionic neuron is going to leave the sympathetic chain ganglia and go to the targets. All right, and if you don't remember that, go back and look at chapter 16. All right, and then that postganglionic neuron that's left the sympathetic chain ganglia area in the thoracic lumbar region is going to head to the targets. And in the targets, it's going to go to the heart, and it's going to release sympathetics on the heart to increase heart rate. And again, let's go through the rule of thumb. If I increase heart rate, cardiac output should go up. Okay, next thing sympathetics is going to do is it's going to release sympathetics, norepinephrine, on the contractile cells of the heart to make calcium come in and calcium remain in a higher amount in the cytoplasm during contraction. And if calcium is more available, contractile forces should go up. All right, and if contractile forces go up, then then ESV should go down, stroke volume should go up. So that by itself should make cardiac output go up. Okay, and then we're going to see norepinephrine and epinephrine on the vasculature are going to make many of my arterioles, not all, but many of my arterioles constrict, and that 1 to 2% increase in constriction is going to make the radius of a lot of my arterioles and muscular vessels smaller, and that's going to make my resistance to flow go up. And so cardiac output goes up by heart rate, cardiac output goes up by contractility and afterload, and my resistance component goes up. So by that equation, remember, cardiac output times total peripheral resistance equals my mean blood pressure I'm going to generate to get from the left ventricle to the right atria. All right, if this is going up because heart rate's going up, this is going up because contractility is going up, and this is going up because arterioles are constricting, then that means there's up, 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 mean blood pressure should go up. All right, and the baroreceptors do this, and therefore they are really, really good if they sense, again, for a few heartbeats, that your stroke volume and your cardiac output and things are not producing enough stretch on those vessels right there at the onset of spitting out blood in the left ventricle. Okay, what the baroreceptors are not good doing is if you are sending out bleep, 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 so much stroke volume under so much stretch that the frequency of these receptors, because they're getting overstretched, is super high. All right, these receptors, when they go to, they'll try to shut off sympathetics. All right, and they're going to try to increase parasympathetics. And where do parasympathetics work? Parasympathetics work by trying to, remember, decrease heart rate. They don't mess with contractility. They don't make calcium not go into the cell. And they don't really make vessels dilate because, again, parasympathetic receptors are not on smooth muscle cells of our vasculature. So when the system of the baroreceptors senses that we have really high blood pressure, parasympathetic outflow can only really try to make cardiac output go down. It can't really change peripheral resistance, and it can't really change cardiac output on the stroke volume end very well. So mean blood pressure might go down, but might not go down very much. And so if the baroreceptors, and this is one of the problems we see with them, if they see high blood pressures for extensive amounts of time at resting conditions, they'll just reset. Because what is the, like right now, if you had white noise going in the background, your ears eventually, the sensory system hearing that sound, are just going to block it out and reset and say, okay, I'm only looking for sounds now that are outside of this background noise. All right. So your baroreceptors do that too. If this is going to be the pressure that you're always sending the blood out with, then I'm just going to reset as it's my new normal. And that's part of the reason why if people start to have a little bit of blood pressure elevation and they're not technically maybe meeting the hypertension diagnostics, we start to get on them about their blood pressure because it's really hard to make a resting blood pressure of 128 over 85, which the average might be only whatever, 106 or 107. That's really hard to bring back down to 100 because your baroreceptors might reset, and 110 average is now your new average. And then it goes up a little bit more, and it goes up a little bit more, and then you start seeing hypertension is really hard to manage because the baroreceptor reflex is no longer really working at those high blood pressures to help you try to bring it down. Okay, so when you think of, again, short-term regulations to blood pressure, the baroreceptors are one of our systems. The other systems we have, again, is the Bainbridge reflex, and the Bainbridge reflex really doesn't care about blood pressure. It cares about protecting the heart. And remember, the right atria is where those stretch receptors are. And the goal is that if I'm seeing too much stroke volume, if I'm seeing too much EDV, I'm potentially damaging and no longer seeing contractile cells overlap, and I'm damaging my heart. So I'm going to try to, again, manipulate my heart rate to make my stroke volume go down, and it might end up slightly affecting my heart, my blood pressure, but the goal is to protect the heart with the Bainbridge reflex. Again, stretch receptors in the lungs, they're not usually there so much to regulate directly and influence directly blood pressure, but they're there to more or less directly protect the heart from overinflation and the lungs from overinflation. That's what I meant to say. You do have some reflexes for exercising and skeletal muscles because we want blood pressure to go up. We want blood pressure to not go so high and stay elevated for long periods of time. And then we have some dive cold reflexes, and then we have some reflexes related to blood pressure going up when we have emotions. Again, for humans, if blood pressure is ever low, we are really good at getting it up in the short term with a lot of reflexes and getting it up in the long term with lots of reflexes. All right. When normal starts to creep up and stay elevated, the system just resets, and our new normal is now this not ideal mean blood pressure that is now a little higher than maybe we would like, right? When we have high blood pressure, and again, outside of exercise and outside of some induced situations where then we can bring it down by just eliminating sympathetic outflow, all right? When we have prolonged high pressures, it's really hard for our system to come down. And that's why when you treat and see patients who have high blood pressure, chances are they are on 2 or 3 medications working at 2 or 3 places on the cardiac output side, on the vascular resistance side, all right, to try to get blood pressure to come down and keep it down so maybe the baroreceptors reset. All right. When we look at the system in a long-term situation, all right, the long-term situation is the radiuses of the vessels, the length, the viscosity, all of that is kind of holding steady. So think of it as you have some pipes, you've bought the pipes are not going to change. The pipes are set at this is the amount of pipe work I have, and this is the average radius that it's going to be forced to go through. So now it's, well, how much volume do I have in those pipes at any given second? And so long-term regulation is usually going to be a hormone regulatory thing, because we're going to regulate the fluid volume. The blood volume, the 5 liters of blood, we try to make it go up a little bit or down a little bit. All right. And the big hormones we have that work in our system really, really well are mostly hormones that help us retain fluid better. And so just like with the baroreceptors, when we have low blood pressure and we kind of have a low blood pressure for a while, the hormones that work best to help us retain fluid and bring blood pressure up are way more potent, way more effective than the hormones we have for high blood pressure to try to help us dump fluid. All right, and the hormones are mostly going to start with the letter A. So aldosterone is remember, a steroid hormone from your adrenal gland, the adrenal cortex, all right, the zona glomerulosa, if I remember correctly. It is considered a mineral corticoid, and aldosterone is going to work on the kidneys to raise fluid volume as an accident in some ways, because it's trying to help us dump potassium ions. Potassium, remember, is supposed to be inside cells. So if you have too much potassium outside in your blood plasma, in your interstitial fluid, aldosterone is trying to help you get rid of the excess extracellular potassium. And as it does that, if potassium leaves, sodium keeps, because sodium and potassium are normally exchanged. And if sodium stays, water stays. All right? So aldosterone is going to help you retain fluid, but it's going to make you lose potassium. Okay? So that's why sometimes we have potassium-sparing diuretics, because we want to lose fluid, but we don't want to lose the potassium. Okay, angiotensin 2, remember from the RAS pathway, it is going to work to, 1, make more aldosterone, 2, make more ADH, 3, make the kidneys work better at retention in the proximal tube, and then 4, cause constriction of the vessels. So it is really, really potent at getting increased blood volume, increased fluid, and small tubing. And so if you only have 4 liters of blood, you're trying to get 4.2, you're trying to get 4.3 with this hormone, and you're trying to make the tubes smaller so that fluid volume is in that tube a little bit better. I'm almost done. Okay, I'm almost done. You're supposed to be at specials or take a lunch break. All right, okay. ADH is going to come from your brain. And remember, that's part of the hypothalamus extension into the posterior pituitary. It's related to thirst. It's related to low blood pressure, low water content. All right, so it makes you thirsty and it makes you retain fluid in the posterior or the distal portions of the kidney. Another signal for ADH is angiotensin 2. All right, so all of those 3 hormones work at different parts of the kidney to make you retain fluid. ADH in super high amounts, so you are super hemorrhaging and lost a lot of blood volume and or super dehydrated. Those are the ways that you are going to see it in super amounts, and it is also going to make fluid volume be retained, but it's going to make your vessels constrict and make your tube smaller. And the goal is, by making the tube smaller, making the fluid volume try to come up, I try to, again, make blood pressure come up. All right? The hormones that try to help me dump fluid, oh, poor babies. All right, you have a nitriactic peptide. You have one that comes from the brain, so it's called brain nitriactic peptide, and you have one that comes from the heart, so it's called the right atrial area, so atrial nitriactic peptide, so AMP and BMP. They work by trying to block aldosterone, block ADH, and block angiotensin. So they don't actually directly tell the kidney to not retain fluid. They just try to block the guys that are retaining fluid from working. So it's kind of like you're grabbing something, and these things are trying to slap the hands as they're grabbing fluid. So they're not very effective. So again, if we have high blood volume, high fluid amounts, we're not really good at really diuretic effect, dumping fluid, because AMP and BMP are working by trying to slow down the guys that are retaining fluid. They're not really doing a great job of working to make the fluid go out, right? And so we give people a lot of different types of diuretics that do then work in the kidneys to block those ion channels, those sodium channels, those potassium channels, those chloride channels, those hydrogen channel, everything. And by blocking those channels, we then can maybe keep more fluid getting lost as urine. Okay, so last slide. Short-term regulation, we regulate, again, our heart rate, we regulate our stroke volume, we regulate contractility, we regulate cardiac output. And things that usually make cardiac output go up without any change to resistance should make blood pressure, the mean blood pressure you're pushing out at the left ventricle, systolic, diastolic divided by 2, that should go up. All right. Things that make, again, peripheral resistance go up, and the biggest thing in the short term is usually the change to the radius. And if, again, cardiac output isn't changing, that should go up. Peripheral resistance, cardiac output isn't changing, so we should see mean blood pressure go up. Flip it. We try to make cardiac output go down with no sympathetic outflow, which isn't great way to do it. Because then we just revert to our normal resting rate. We try to make cardiac output go down with parasympathetics, but parasympathetics really only work on heart rate going even lower. So again, heart rate goes down, cardiac output goes down a little bit. Nothing's changing on resistance, so peripheral resistance may go down a little bit, but not really that much. All right. And then anything long-term is usually we need to get 5 liters of blood moving through the system. The vessels are not going to change for their radius to get that fluid through the system. So how much fluid is in the system? And normally, again, with all the hormones we have playing, we are really good at retaining fluid. So we usually have a lot of blood volume. And if we need to retain blood volume because we've dehydrated and lost a lot of fluid, we are good at doing that, but we are not good when the blood volume is elevated at dumping it. And that's why we normally give people who need to dump fluid, need to, fluid for a variety of reasons, edema and high blood pressure and other issues, we give them diuretics. We have to be careful though, because diuretics mean we need to make sure sodium stays in the urine so water stays with it. And to do that, we have to make sure we either retain potassium or not forcefully lose potassium. So we have to worry about potassium sparing. All right, that's all I have for today. Again, I'm going to stop the recording.